Thank you, Karen and Kate. So let's get started. I'm going to keep my introductions very brief. There are bios in the booklet, so you can see much more detail to save time. So I'm very pleased to bring up our first speaker. Jeffrey Samet is the Professor of Medicine and the Chief of Section of General Internal Medicine at BMC. He's also the Vice Chair for the Department of Medicine for Public Health. Jeffrey's my boss, and I've known Jeffrey for as long as I've been here, since '91, so it's a real pleasure to ask him to come and speak.
Good, thank you, Chris, and thanks for giving me a couple of extra minutes. No, just joking. Okay, I think it's fitting, welcome everyone, I think it's fitting that we start with workforce, because in a way we respond to Karen's quest from the very get-go, which is what can we do to help? And part of what we can do that's really quite effective is we can develop the workforce. And that's what you're going to hear about. And I'm going to tell you a tale, and many people in the room are part of this tale. And it's about a local tale of how it all happened at BMC and BU, and the support that it takes to do that, and how these things don't just happen, but with the right combination, it does happen. Okay, so we've gotten good at logos, and these are just some of them. Workforce development. So Ed Bernstein and a few others that you'll see here showed up on campus. We showed up in the late 80s, early 90s, and we thought addiction would be a good thing that this campus could develop in, and we could develop people. But we realized we didn't know enough to do much about that. So we wanted to learn, and at the same time, the government, who wanted people to start teaching this, at least in medical schools at that point in time, realized that, you know, it's not being taught, but it's not being taught because there's no faculty that know anything about this. So they said, why don't we put together faculty development programs? And what they wrote, and this was at SAMHSA dollars, or the predecessors of SAMHSA, the faculty development programs aim to develop a cadre of skilled faculty with professional identification in the field of alcohol and other drug abuse in each participating institution. So they were going to fund 8 places around the country. About that time, there were about 120 medical schools. 8 places around the country to become expert in addiction, or at least have 4 or 5 faculty that are expert in addiction, which is a good start. And found Ed and scrounged together and said, like, ooh, who can we find? Lily Awad, who was a young psychiatrist then. I'm still committed to this, and Linda Grant from pediatrics, whose picture I couldn't find. We all agreed to take part in this, and for 3 years, we got smarter. Of course, who do you get smarter from? John Renner's in the room somewhere. He was the person who held the most knowledge on this topic, and he agreed to help us with this, along with others. And then they said, okay, well, that was a good start. Let's do it again. Let's train more people at places around the country. But of course, the places that were trained were in the best situation to put in the best grants to go at it again. And so we had a second cohort here. So we were one of the second 8 as well. There's a story to this. And great people were trained in that. Pictures of Rich Sates, who's speaking today, Gail D'Onofrio, who moved on to Yale and is chair of emergency medicine there and a leader in this stuff, and others whose picture I don't have. And then they even did a third cohort that embraced schools of public health, schools of social work need to be involved. There were other schools that were, and this was part of the group that was collected at that point in time. So just to show you that they really invested, and it really made a difference in our institution. Of those people they invested in, they were mostly doctors initially, but they got broader than that over time. There was, at the same time, an organization that said, we believe in developing the workforce of people in the addictions and interdisciplinary approach to it, MRSA. And so I'm just saying, the story that I tell today weaves in national efforts with local efforts, but sort of showing how what's happened at Boston Medical Center and at BU School of Medicine, School of Public Health, have really done much to advance the national scene in this realm. And so 3 of us at this institution had major leadership roles, although many people have been involved. And this is an organization that was committed to health professional faculty development and substance use. Okay? That's why it was a small organization in the mid-1990s, because, you know, that was a new idea, but growing idea. And Kate Walsh mentioned the Chief Resident Immersion Training Program. So you can tell that this faculty development grant for the feds put out was a good idea, but wasn't going to deal with the issue, right? 120 medical schools, and they're even growing in number, and they didn't have people who had faculty that were educated. So we said, maybe let's try to build something that might get a broader swath of the medical schools in the country. And this idea of a chief resident immersion training program is grab chief residents before they're going into their internal medicine, family medicine, emergency medicine rotations, and bring them together for an immersion course and have them leave with a plan to educate people at their institution. So we could take 20 at a time, and that's better than 8 over 3 years. It's 20 at a year. Anyway, that was the concept. And this was actually last week's crit, so that was a long time ago. And we've been doing this since 2002. I see Marianne Modio here. She joined us from the School of Social Work at BU. She joined us for the first 10 years or so, maybe 15 years of this one, before her retirement. But this is a course that actually brings chief residents from around the country. It's fascinating to hear what's going on in different places around the country, to advance their substance use knowledge, clinical practice, teaching skills. We teach them about substances, lots of experiential education, going to 12-step meetings, having guests with lunch and recoveries, learning about naloxone rescues, clinical skills training in small groups, role plays. We call it skills practice. They don't mind as much. And we teach them how to be better teachers, so they can go back, because that's what they're going to be doing, in part, in their chief resident role. So that's been a program that's actually been pretty successful. We have like twice as many applications for the number of spots we have each year. And, this is stuff that we've written about, and we've shown that, basic stuff, that 6 months later when we look at them, yeah, sure, their knowledge has increased, their confidence has increased, they're more prepared to take care of these patients and teach about it. That's the key thing. And actually, they've done teaching projects so that they're part of the workforce development, okay? It's a few steps there. And in one of our offices, we have a picture of each of the years. So this has been going on for a long time, and it's really cool when someone comes up to you and says, I was at that crit course in 1910. You go, or whatever, 2010. It feels like 1910. Okay, but moving on. So, kind of reflect, nationally, there's places that work on developing workforce too. And in the physician realm, the American Society of Addiction Medicine has been quite active in trying to develop the addiction workforce. That's what their mission is, physician-led professional community for those to prevent, treat, promote remission, recovery from the disease of addiction. I put them out there because they've been important, because people locally have been highly involved. Rich has been editor of the journal from that organization, and John Renner has been Massachusetts president these last couple of years. There's people that have been involved. I'm just giving you a taste of it. But I'm also putting this here because ASAM gave birth to a very important phenomena, which is the American Board of Addiction Medicine. I'll explain that to you in a bit, in part because it's important in terms of workforce development, and it's important because, again, BMC was at the table when this was all happening. So the American Board of Addiction Medicine, what's it about? Its goal was to gain recognition of addiction medicine as a medical subspecialty by the American Board of Medical Specialties. The ABMS is the official, you're blessed or you're rogue organization in the scheme of things of organized medicine. And in truth, to get blessed, you have to go rogue for a while. That's the pathway to getting blessed. And this organization was, the American Board of Addiction Medicine was to bring people together to go down that pathway, develop subspecialty training fellowships in addiction medicine, and get approval of ABMS. It typically, if everything goes well, it can be a 10-year course. And in fact, we began, you can't see that too well, the logo says began in 2007, and in 2016, the efforts of this group achieved ABMS approval. So now, addiction medicine, it took the rest of the family of medicine 20 years after psychiatry sort of caught on and developed addiction psychiatry in the early 1990s, but addiction medicine now, for all the other specialties of medicine, can go down this path as a subspecialty. And in that period of time, part of the pathway of getting there is developing subspecialty training programs in addiction medicine, fellowship programs, and over 50 programs around the country have been developed. ACGME has come around. They're starting to ask for applications, so they're now the approval process for residency training, and so it's all no longer rogue. It's actually quite official. These were, I put this one up here thinking Dr. Volkoff would be here because she cares about physician education and addiction medicine and has written about such. And then the addiction medicine being a new discipline was written about as well. This was the group. I put this as the group, the board that was together for lots of years working on that. 2 of these boards from different disciplines were from BMC. Okay, so again, local, national story. Addiction medicine fellowships. When the first addiction medicine fellowships began, it was seen as a story. It was a phenomenon. The New York Times wrote it up. And what they wrote up, what you can see down here, is 10 medical institutions just introduced the first accredited residency programs in addiction medicine. Well, no surprise, since that's the theme of my story. BMC was at the table, one of the first 10 to be created, and this is our own Christine Pace, who was one of our first addiction medicine fellows, along with Karsten Lindsay, who's somewhere in the back there, taking care of one of our patients. And this was the beginning. Okay, if you're going to build an addiction workforce, we've talked about clinical training, we've talked about education, but this is academic medicine and this is medicine. You have to have a research infrastructure that supports that. And that's part of what brings us together with the CTSI today. At BU, we've been very good in this domain, I would say. This was the slide I wanted Dr. Volkoff to see, that 6 of our faculty at BU, between the School of Public Health and the School of Medicine, have K Awards looking at cutting issues in the field these days, be it benzos and opioid agonist treatment with Ted Park from the Department of Psychiatry, Angela Bazzi in the School of Public Health, talking about pre-exposure prophylaxis for people who inject drugs. Sabrina Azamu from Infectious Diseases, who's trying to engage young people who inject drugs into HIV and HCV care. Karsten Lindsay, who looks at stigma, a big issue that keeps people from therapy, actually in Eastern Europe. Sarah Bagley, who's looking at emerging adults and interventions to engage them in the opioid agonist care. And Mark LaRochelle, who looks at issues, a lot of issues, including what Kay looks at, which is urine drug tests and how do we use them most effectively. So we're very proud of this group, and we have yet another one on the threshold that we hope we will have to have 2 slides to do this one next time. And then just to note that there are past awardees that have gone on to claim and fame in other places, but were trained here at Boston Medical Center and BU School of Medicine. Professors of medicine in Pittsburgh, in Alabama, and at UW. So there's other ways to educate people, and one other way is to get them current data on what's going on. And this is a newsletter supported by one of the NIDA grants, Alcohol, Other Drugs, and Health, Current Evidence. And it's this free online newsletter. It comes out, I want to say 6 times a year, to give us the latest update, concise, in the way that the stuff from New England Medicine, what's that? Journal Watch does. It was really with that concept in mind, and it's very good. Rich Seitz is the editor of it, and there's a group of great addiction physicians who are associate editors. So all this moves workforce. Another piece in the effort nationally to take advantage of the creation of addiction medicine fellowships is to say, and that NIDA supported, is to say that, look, if they're going to exist and you're going to train them to be clinicians, that's great, and they can be teachers of the future, that's great, but some of them should go down a path with research. And so we said, well, it's not going to happen just by saying it. And NIDA bought that argument. It was made a little more loquaciously than what I just said. But in building a program to support people who are in addiction psychiatry and addiction medicine fellowship training to have a better chance of going into research careers. And that's what this says. Not that they train here, but that they come here. It's a supplemental support. And we call it the Research in Addiction Medicine Scholars Program, the RAMS program. And we have, this is just 1 year of fellows, and they're from all over the country. The people you stand, the person next to me is a partner from Yale, Patrick O'Connor, who we lead that creature together. But NIDA's been very supported, and we're moving into our 6th through 10th years with this program. Another piece of the sort of workforce development, which is very broad and has touched many people, is Part of what brought us into this particular opioid crisis is how we're prescribing opioids for pain. And Dan Alford, one of our associate deans at BU, has led this effort, really a national star in safe and competent opioid prescribing. Him and his team has gone around the country, given oodles of talks. Thousands of people have seen it. My son, who did the route applying for medical school this year, told me, oh, I met someone who knows you. He said, say hi. He said, he knew Dan Alford, who's at BU too. He says, he thought Dan was really great. Anyway, but Dan gets around, and you know, he is really great. Anyway, this program's out there, and a lot of people are learning good stuff from it. This is to say another realm, and so this first part was really way more physician-focused than it merited, but I did it because we're talking from a medical school point of view. But a heart of what goes on here is the office-based addiction treatment program that exists at BMC, but what's happening that's mind-blowing is that it's being spread not just all over Massachusetts, but all over the country right now. And this is an effort that's been led by nurses at BMC, and you're going to hear more from Colleen LaBelle, who's going to tell you in detail. I just wanted to put it on your in your head that this is a key resource to be developed, been recognized. The Surgeon General came and visited this program a couple of years ago. But in short, thousands of healthcare providers and nurses in a way that are really remarkable are being trained to provide this type of, to develop the workforce. And just in the last couple of years, really in the last year, doing this with this new technique called ECHO, which stands for Extension for Community Healthcare Outcomes, but it's this thing developed for hepatitis C therapy to get it out in the community, is now being used to get buprenorphine care out in the community. It's not that hard to do, but it's not that easy either, so people need some help. This is helping them. Okay, this is my favorite slide, and I told Kate Walsh before she goes, this is one was with her in mind to boot, that this is the banner that I want to see hung over the entrance to the medical school and the hospital. We are the best medical center in the country to care and educate about patients with alcohol and drug problems. Pleasure telling you the story. Happy to take a couple questions as per Chris's desire.
You left them speechless.
So, Jeffrey, you kind of gave us a history here. So what do you think about the work ahead, right? So where do we need to go in terms of kind of training and education as we move forward?
Well, I'd say on the local scene, there's local scene, national scene. From the local scene, what is impressive is things only exist in terms of the education as long as there's a focus, commitment, and someone there to make it exist. It is amazing how quickly efforts around this can evaporate if the right people aren't around and the right energy and the right leadership to say this is important is saying it. So that's one piece, and I think we have it right now, but I'm never feeling like, oh yeah, we don't have to worry about it. We continue need to push that. And then that said, that just speaks to, we have such a wealth relative to many other places in terms of expertise here. Think of what it's like if you're at other places in the country, not to be named, but you can name almost any of them. It's just the bench is not as deep in those places. And so programs to train people are not that well supported. You know, should this be a piece of the CTSI workforce development piece, maybe in the addiction realm? I don't know, but these are ideas. They're just creative ideas that people should be thinking of to put out there. This was just to say a few local ones that we've tried. David.
How do we embed the ideas and train more of the physicians and practitioners in the community health centers and other providers around the area, and then nationally? It's great to have specialists, but the vast majority of the care is likely going to be given by primary care providers.
Yeah, no, great question. It's like, how do we spread this to the community? It's kind of like what Karen's call to action was. How do we make this felt on the ground? And you're going to hear more about that from Colleen LaBelle when she speaks about the nursing effort. It is incredibly exciting to see what's already been done. The health centers are up and going in large part because of the efforts of the nurses in leading that pathway there. And But more creative things need to happen. The ECHO is an example too. So all hands on deck in terms of, it's great to have people from social work school here, from main campus, nursing and public health, because it's really lots of ways of getting at it.
So one more question, because we have time, and I'll take prerogative. Can you just talk about some of the work that's being done to educate other professionals, for example, in the criminal justice system, other ways to extend the education, not necessarily clinical, but addressing some of the other gaps that are in our total system?
Yeah, I think people are catching on. Well, in part, this is the AIDS epidemic of the 2010s, in a way. More people died of overdose this year than at the height of the HIV epidemic in the 80s, 90s, which is pretty mind-boggling, having lived through that. But so other people are saying, how can I help? And the criminal justice is one group that used to be not as allied, but now there are very many interested partners. I think we have to be willing to be present, and it's not always so easy. So when they ask you to be on their board, or they ask you to come and talk, there's only so much you do, but that's why you want to train other people, so that there's more people available to get out there and spread the word. I think being willing and then speaking up at the times that might be useful. That speaking up might be writing a perspective piece, might be writing something in the paper, might be going to your city area and communicating at your local school. Can't deny the dean.
How important are increased numbers of treatment facilities, specifically the mayor's plan to actually put a treatment facility out on Long Island?
Where will I go with that? I'd go, look, I think having treatment available is key. What the right mix of treatment in terms of residential versus outpatient is something that needs to be talked about. And is really important because of the effectiveness, at least with opioids, of medications, so much treatment can be done in the outpatient realm. But there are other people, it sounds easy, but when it's complicated with multiple substances and they're homeless, then residential becomes important. So it's not a straightforward answer, but at least we're moving in the right direction now. Thank you.